Hello, I'm Tanya Dorff, the Section Chief for Genitourinary Cancer Program at City of Hope. And a big theme that emerged in the world of prostate cancer this past year was intensification of systemic therapy in earlier stages of disease. So we'll start with the PRESTO study, which was in the setting of biochemical recurrence after prostatectomy and salvage radiation. When men were facing rising PSA yet again, the question arose with some of our newer, more intensive and more effective hormonal therapies, could doubling down or even tripling down lead to eradication of micrometastatic disease? So the study was a randomization between 1 year of LHRH therapy alone or with apalutamide or with a combination of apalutamide and abiraterone. The primary endpoint was PSA progression-free survival, but they will be looking at some firmer oncologic endpoints such as metastasis-free survival. Patients did have to have a PSA level of 0.5 in order to enter and a doubling time of less than or equal to 9 months. If they had findings on PSMA PET that were not visible on conventional imaging, they were still categorized as biochemically recurrent and eligible for the study. And I think that's just an important side note for the world of prostate cancer. We're all grappling with these new PSMA PET scans, but most of our studies are still using conventional imaging to categorize, and therefore our treatment paradigms are really based around that. So the patients definitely did better when they had double or triple therapy. The two apalutamide-containing arms were combined for the primary analysis, and you can see there was a prolongation of PSA progression-free survival. In terms of adverse events, you can see that there were more treatment discontinuations on the double and triple arms, as well as a higher rate of grade 3 and 4 adverse events. And looking down at the bottom, these include a little bit greater rate of fatigue. There's also, of course, the potential for rash with apalutamide, and hypertension is something we have to watch a little bit more carefully as we intensify our hormonal therapies. So this is not yet really maybe on label. It's not clear whether it will become something that FDA will review. But it fits with the whole spectrum of what we have been seeing in other stages of prostate cancer. So, Formula 509 is a great example of that. So here is taking one step earlier, biochemical recurrence, not yet treated with salvage radiation. And here the same question was essentially asked. We've heard from the SPORT trials as well as GATUG in the setting of salvage radiation that adding ADT increases metastasis-free survival. But here the question was, could we intensify and achieve even a higher rate of cure? So in this study, patients receiving salvage radiation, again with a PSA level that had reached stratified for PSA of greater than 0.5 or less than 0.5. So they did allow treatment to start a bit earlier, as is common with salvage radiation. 6 months of just castration therapy with bicalutamide, one of the older nonsteroidal anti-androgens, or a triple therapy with LHRH plus abiraterone plus apalutamide. So this was just reported at GU ASCO by Paul Wynn. And you can see that there was a significant improvement in the 3-year metastasis-free survival from 66% to 84%, leading to really a pretty favorable number needed to treat of 5.
The main question I wanted to ask you about both of these trials, and again, we can talk about it more with Oliver, but in a way, I'm not exactly sure of the impact of the control arm versus doing nothing. So in other words, do we know, for example, that ADT adds to salvage radiation after prostatectomy? And do we even know whether or not treating people, with the doubling time less than 9 months, et cetera, is better than not treating at all? Is that even?
Yeah, so those are
I know it's a basic, yeah.
Two separate questions. So with regards to PRESTO, Is early hormone therapy impacting survival in the setting of biochemical recurrence? There are not really strong data. The single trial that we all refer back to over and over again is the TROG trial, which did suggest that there was a survival advantage if you started ADT before your PSA reached 5. And for patients with a doubling time less than 15 months, compared to waiting for metastasis to develop. But it has become more accepted that metastasis-free survival is significant. So patients may be willing to accept hormonal treatment simply to avoid seeing the cancer growing in their bones, for instance, and it would delay the time to having a symptom from their cancer. But separately, for Formula 509, in the setting of salvage radiation, there were 3 trials that showed increased cure rate when you added ADT to salvage radiation. So that has been answered. It's separate from biochemical recurrence beyond salvage radiation. But that was the SPORT trial, the GETUG, and then there was one other, radiation alone versus radiation plus ADT. All 3 favored adding the ADT.
Great. Okay, that's very informative. And of course, yeah, the biochemical relapse question has been out there forever, and I guess it'll probably never really be answered. But as you say, let me ask you another question. From your point of view, I mean, putting aside your approvals, would you like to be able to use these strategies right now?
There are patients for whom I feel like getting a deeper remission is helpful. I'm still kind of grappling with weighing that against the toxicity, and I really want to see the testosterone recovery data because my experience on the Presto trial, I had 25 or so of the patients on that trial, is they did have more toxicity, and it felt like it took longer for testosterone to recover. So I think all that information has to go into the discussion. But I do have patients right now for whom I do want to use intensification, and we can usually get it approved. But I do have other patients for whom I'm still using monotherapy.
And just to clarify, when you treat people in the, I guess the Presto scenario, biochemical recurrence, in that situation, it's indefinite treatment?
It was 1 year. It's intermittent.
Just 1 year. But I mean, normally when you have a patient who has a PSA relapse, let's say doubling time less than 6 months. You do short term or indefinite treatment?
Oh, short term. Mm-hmm.
And then stop.
Yeah. I find that those breaks, I mean, first of all, JPR7 said that intermittent versus continuous in the biochemical recurrence setting, you had equal survival. You had more deaths from cardiovascular disease at 10 years on the continuous arm. You had more deaths from prostate cancer on the intermittent arm, but the same number of men were alive at 10 years. So that forms the basis for continued use of intermittent therapy. But honestly, from quality of life standpoint, JPR7 clearly favored intermittent. And that's what we see as well. You actually do get reversal of some of the toxicities during those gaps when testosterone recovers. And those, I think, provide very meaningful benefits to these patients. And the switch, once you switch to long-term continuous, that's a big deal for patients.
Yeah, no, I was actually just, when I said, is it temporary or not, what I meant was, intermittent therapy, but that you don't stop it. So is that the way you approach it? That you treat them, the PSA comes down, and you stop therapy, let the PSA come back and restart, or you just treat for a year and stop treating? I'm sorry to ask such a basic question, but I just don't know the answer.
Oh, no, intermittent implies that we know PSA is going to come up when testosterone recovers and we will go do another cycle. So the intention is that they'll be on and off treatment just with gaps.
Right, yeah. It's just terminology. That's what I meant, that this would continue indefinitely, the intermittent therapy.
Until they switch to continuous, yeah.
Great. Okay, please continue.
So, of course, when we're looking at benefits, we also have to look at toxicities. And again, apalutamide, one of the most notable toxicities is the rash, as well as a high rate of hypertension. So we will be talking a little bit about rash management a little bit later, but that's part of the conversation we have to have with patients. We can improve metastasis-free survival. We can delay the cancer coming back, but here's what you're going to go through for the 6 months or the year that you're on this treatment. So continuing with that theme of earlier intensification, a couple of the STAMPEDE arms, which, we think of STAMPEDE as a metastatic hormone-sensitive prostate cancer trial, the same way we maybe categorize CHARTED and LATITUDE and ENZAMET. But in fact, there were a fair number of non-metastatic prostate cancer patients who were eligible and included in STAMPEDE. So two of these arms became relevant in answering a question of whether intensification was beneficial in earlier stages of disease, non-metastatic. So that was the abiraterone arm and also an arm with abiraterone plus enzalutamide. So Gert Attard published in Lancet last year a meta-analysis where he pooled the data from these two arms for the non-metastatic population. And what was shown was that the combination therapy, whether it was the doublet or the triplet, resulted in significantly longer time to metastasis, as well as overall survival. And the treatment period in these cases was 2 years. So this forms the basis for allowing us to recommend adding abiraterone on top of castration therapy in a high-risk localized setting or a high-risk biochemically recurrent setting, even though the trial wasn't specifically designed. But the meta-analysis, you can see that survival curves for metastasis-free survival are quite compelling. There's a big difference when we add the stronger therapies early on. One other theme that emerged was the use of PSA response as a biomarker that is prognostic for overall survival. So we saw things like the ICECAP and STOPCAP groups looking at some of these big trials and showing that a PSA nadir below a certain level, less than 0.2 at 7 months, very prognostic for survival. So an analysis was performed from the non-metastatic CRPC trial called Spartan, which was with apalutamide. So these are men on castration therapy for biochemical recurrence who become castration resistant, but their scans are still negative. They were randomized to apalutamide or placebo, and you can just see these deep PSA responses on the waterfall plot with the apalutamide. In fact, 90% of patients achieved a greater than 50% drop in PSA by 6 months. So this is not yet a biomarker that's been validated as a surrogate for metastasis-free survival or overall survival, which were the endpoints in Spartan. But I wouldn't be surprised if we start to see this PSA response biomarker being more widely applied. They did show in this particular trial that the deep PSA response, less than 0.2, was associated with overall survival and not just time for PSA to recur. But again, I would say this is not yet quite as validated as this same biomarker in the metastatic setting.
Let me ask you, how come the waterfall plot on the placebo arm doesn't come down? Because they're getting ADT, right?
But they're already developing castration resistance on the ADT.
Oh, right. The castrate. Okay, I was
So it's
thinking it
actually
was
surprising any of these guys drop. I don't know what happened to those guys.
Yeah, Actually, that's a good point. Yeah, maybe they. Yeah, interesting. Okay, great.
So as I mentioned earlier, with apalutamide, one of the major side effects that can be seen is rash. And this has many different manifestations. So there was a very helpful publication last year just kind of describing, it ranges from dry skin, xerosis, to maculopapular rash. There can be oral finding of lichen planus, a little bit less common. It can be sometimes acneiform or looking like psoriasis, but primarily it's going to be more of a maculopapular erythematous eruption. And there's a number of wonderful photographs in the publication, and one of them is presented here. Now, how do we manage this rash? Well, first of all, it's important to note the median time to onset is 80 days. So if you don't see it in the first month, it doesn't mean your patient is in the free and clear. You have to warn them that if a rash comes on in the second or third months, that it's likely still related to apalutamide and they should still call in so you can give them guidance. I often stop the drug and then apply topical corticosteroids. Antihistamines can be helpful if it's very itchy. And so you can see a distribution of what types of treatments were used. There are some patients where we just stop drug and don't administer any specific treatment, and the rash can go away. Certainly in those cases, it's easy to see where you'd want to re-challenge, sometimes at a lower dose. When patients do require oral corticosteroids, then that might be a scenario where you'd be less inclined to re-challenge.
Quick question. I'm assuming that people have looked at whether there's a relationship between rash and efficacy.
Yeah, I don't know that that was in this publication, actually. I don't think I've seen those data, but I'll have to go back to this publication.
About what fraction of patients actually get clinically meaningful rash that require, intervention?
About half.
Yeah, I would imagine, probably it's not correlated, but I'm just kind of curious.
Yeah, it would be interesting to understand like what the basis of it is. So one question that many of us have is how are patients with prostate cancer and visceral metastases fare with some of these newer intensified strategies? Because when we think of visceral metastases, we often think of maybe more of an aggressive variant, maybe something that's less hormonally driven. And so there was a very helpful analysis published in the European Journal of Cancer last year, analyzing the Latitude trial, which was with abiraterone in metastatic hormone-sensitive prostate cancer, and pulling out the subset of visceral patients. So what you can see here is that there was a significant improvement in the median overall survival from something in the range of the 30s for placebo up into the 50s with abiraterone. And that held true whether you had a more traditional pattern of metastases or whether you had visceral metastases. So I think this is very helpful when we're looking at doublets and triplets and whether we want to add docetaxel to have this kind of nugget that tells us that even though this patient has a little bit unusual presentation, they could still benefit from a traditional AR-targeted agent like abiraterone. And that is also important when we're trying to talk to our patients about which way we're going to intensify therapy with an AR-targeted agent or chemotherapy, since we know both can prolong survival. So we want to be able to show them what their quality of life is going to be like. The chemotherapy that we use in the upfront setting, of course, is 6 cycles. So that is 4.5 months. And so in this quality of life analysis from 2 of the arms of Stampede, the arm with docetaxel and the arm with abiraterone, you do see a sharp drop-off in quality of life during the initial treatment with docetaxel that then sort of recovers to baseline within a year, whereas the abiraterone treated patients tended not to have a steep drop-off in their quality of life. So I think, this is not maybe surprising to many of us. We know that during docetaxel chemotherapy, there are periods where patients feel ill, but it is nice to see that the quality of life rebounds as patients recover from that time period. And overall, that quality of life with intensified therapy using abiraterone is maintained. There have been many, many analyses from the Stampede and Latitude trials. These are very important studies for the world of prostate cancer. One big question, because Latitude was designed only in a high-risk metastatic hormone-sensitive prostate cancer population, whereas Stampede allowed much more of an all-comer population, including non-metastatic, as we saw earlier with the meta-analysis. So people have been waiting to hear from the Stampede group about subsets and who benefits. So they did perform an analysis looking at the Latitude criteria that defined high risk and looking at whether survival was favorable with abiraterone in a non-high risk subset, a population that would not have been included in Latitude. So here you can see the high risk subset in graph A and the low risk or not meeting the Latitude high risk criteria in B. So essentially we're seeing a similar effect favoring intensification with upfront abiraterone regardless of risk status. So this just helps us better extend these kind of big clinical trial findings into our day-to-day practice. The ARCHES study using enzalutamide in metastatic hormone-sensitive prostate cancer is one of the other seminal papers that has created this shift in how we treat prostate cancer. And again, there's just been a lot of interest in subsets. So there was a publication by Andy Armstrong and colleagues looking at things like high volume and low volume. And you can see this forest plot essentially shows that upfront intensification, in this case with enzalutamide, is really beneficial across the board. One other question that had arisen in this whole conversation about triplets versus doublets is they did have some docetaxel use in ARCHES, and so they did pull out that subset as well. You can see towards the bottom. The benefit of the upfront enzalutamide was maintained regardless of whether the patient had received the docetaxel, so paving the way for triplet therapy using this combination. We also saw an update last year from Enzamet, which was also a study of enzalutamide in metastatic hormone-sensitive prostate cancer. And what really stood out to me, this study had a significant use of docetaxel, quite a bit higher than what we saw in ARCHES. And so they were able to look at, again, whether enzalutamide was still beneficial even if you had received docetaxel. And the group that really stood out was those patients who had de novo metastasis, or what we call synchronous metastasis, and high volume. So that includes 4 or more bone metastases with one outside the axial skeleton or visceral involvement. So in the circle part of the Kaplan-Meier curves, what you see is very early on, triplet therapy, enzalutamide and docetaxel added to LHRH therapy, really separates out these synchronous high volume patients and preserves their early survival. So this is a group for whom I really push a conversation about triplet therapy to include not only an AR targeted agent, but also docetaxel.
So I was asking Oliver about this, and I was going to ask you the same question, which is in hormone-sensitive metastatic disease, do we have any evidence that adding chemotherapy yields any benefit beyond ADT plus, secondary hormonal therapy? Is there evidence?
Yes.
Is that what this shows?
So there's no sort of level 1 evidence. There was no study designed to ask that question, but these subsets do allow us to see, because this is the gray line is triplet, the black line is doublet, and you can see this early separation, which would suggest that for these patients, the early docetaxel was quite beneficial. It kind of saved them from early mortality, within that first 2-year period.
Right. Okay, great. Yeah, no, I see it there. Interesting. Could I just ask you, so then it sounds like there are situations where you are using triplet therapy, because Oliver said he basically almost never uses it. I said, what about young patients with a lot of disease? He said, not usually. But your answer is more like usually you do that?
Not usually. So many patients present with much less aggressive disease than what's
Right,
represented here. But for
right.
those patients who present high volume de novo, younger, low PSA for volume of disease, I definitely have some patients on triplet therapy right now. The majority are doublet, I will say. But I think it's important to call out people like this where significantly more of them are alive at 2 years who got triplet. I think that's really important.
All right, please continue.
So many of our patients are concerned when we discuss with them a reduction in the dose of their treatment because of side effects. We're always trying to balance longevity with quality of life. And we're sometimes reducing some of these powerful AR targeted agents due to fatigue or other side effects that we're seeing. So this was an interesting analysis looking at the relationship between dose exposure and response in the context of apalutamide for metastatic hormone-sensitive prostate cancer. So similar to some of the other drugs in the class, it takes at least 4 weeks to achieve a steady state. So they did these complex calculations for AUC after patients had reached a steady state. And then they analyzed quartiles to see whether those patients who maintained a higher dose level or had a higher pharmacokinetic level had better outcomes. And I think what stands out to me is, at least for progression-free survival, that lowest quartile of drug exposure doesn't do as well. It eventually ends up with a little bit of a difference in the overall survival curves. But I would say generally this is pretty reassuring. Quartiles 2, 3, and 4, we don't see a lot of difference in the curves, which should mean that we're able to dose reduce for toxicity. Of course, we don't have the pharmacokinetic data to guide us, but this is suggestive that benefit can be maintained. And sort of a flip side of how I talk to patients about dose reduction is in the phase ones, where they dose escalated drugs like enzalutamide, they saw efficacy at lower doses. They explored a wide range of doses, and they didn't pick the maximum tolerated dose. They picked a dose at which they were seeing a nice balance between responses and toxicity, but that didn't mean they weren't seeing responses with some of the lower doses. So now we'll move on to triplet therapy. The ARASENS trial was really one of the only trials that specifically intended to have everyone receive docetaxel and then randomize patients to darolutamide, the AR targeted agent, versus placebo. It does not answer the question of what did the docetaxel add. Unfortunately, we don't have any studies that do that. But it did answer the question that even if everyone is getting docetaxel and we're not just doing a post-hoc subset analysis, but even in that context, receiving darolutamide did result in significantly better survival. A lot of these trials are unfortunately plagued by a lack of racial diversity, and that is a limitation in terms of treating the real patients we see in our clinics. But age, I think, is an important question a lot of clinicians face. Should I intensify even in my older patients? So we can see in ARASENS that at least 16% of patients were over 75, although not a lot of octogenarian representation, probably because of the chemotherapy in this trial. But there are studies of chemotherapy in older populations. I think docetaxel, for the most part, really can be tolerated even in older patients. The toxicity in ARASENS that I wanted to highlight was febrile neutropenia, which I think we can clearly say is related to docetaxel. And it was 7.8% on each arm. So adding the darolutamide did not exacerbate chemotherapy toxicity. And it's up to clinicians to think about whether that risk is an acceptable range for offering triplet versus pursuing a doublet with an AR targeted agent. At GU ASCO this year, Maha Hussein presented a subset analysis for high volume and low volume, as well as high risk and low risk. So these are using the charted criteria, again, 4 or more bone mets with one outside the axial skeleton, or visceral involvement is what qualifies you for high volume. And you can see that there's definitely a stronger signal for benefit in the high volume subset, although there is a trend even for the low volume in favor of triplet. When it comes to the latitude high risk definition, versus low risk, I think there's a little bit more consistency across the results. So, bottom line is we don't have great biomarkers that tell us which patients need intensification and which patients can get away with maybe less treatment. There is a lot of work ongoing analyzing some of these big pivotal phase 3 trials, like Charted has published, looking at basal versus luminal, as well as using Decipher genomic classifier risk scores to try to tease out. So eventually we hope that we won't be treating every metastatic hormone-sensitive prostate cancer patient the same, or using things like synchronous, metachronous, high volume, low volume. But I think the sum total of these subset analyses that we've just looked at in the context of triplet therapy do give us a little bit of clinical guidance. Piece one is the other trial that people talk about as triplet. This is a very complex study. It was initially more of a 2x2 factorial, asking the question of whether radiation to the prostate primary was still beneficial when we intensified systemic therapy, because the prior STAMPEDE arm that showed radiation to the prostate primary was beneficial was in the context of castration alone and not what we would consider optimal systemic therapy in the modern practice. However, as this trial was being done, Charted reported out STAMPEDE docetaxel, and so it would not be ethical not to allow patients to receive docetaxel. So this trial was not designed to answer the question of triplet therapy with docetaxel, but it does give us some evidence about this. So they were able to show statistically that there was no interaction between abiraterone and receipt of radiation to the prostate primary, which allowed them to lump those patients for an analysis of docetaxel. Of the docetaxel treated patients, and ask the question of benefit of abiraterone versus no abiraterone. Again, not answering the question of the docetaxel contribution, unfortunately. But what we saw was across the board for overall survival, there was a benefit when you added the abiraterone, and that held true whether or not you got docetaxel and whether you were high volume or low volume. So the new paradigm in metastatic hormone-sensitive prostate cancer is intensified therapy. Most patients who present to our clinics can tolerate doublet, and we have a choice of agents so that we can look at their comorbidities and look at their concomitant medications and make a choice that's going to fit well for them. We have to think about triplets for certain groups, but I am open to triplet therapy as part of a clinical trial. We have some really great active new agents like lutetium-177 PSMA that's moving into clinical trials in the hormone-sensitive setting. There are also a lot of molecular agents that we'll look at very briefly in a moment. But we also have to think about treating the prostate primary, because there are data that suggest radiation to the prostate, if it's previously untreated in a low volume metastatic patient, is going to be beneficial. If they are higher volume or don't quite fit into that, we do have an ongoing trial through the cooperative group, SWOG S1802, that's trying to answer the question of cytoreductive prostatectomy in the face of intensified systemic therapy or radiation to the primary. So it's a randomized trial comparing that kind of local treatment versus no local treatment to answer the question of whether that is beneficial. And then there's a whole gray area when it comes to metastasis-directed therapy in low-volume patients. So there's a lot to talk about with our newly diagnosed patients, but clinical trials remain a very good option. And this is a select list of some of the trials that are going on in the metastatic hormone-sensitive space. You can see some of the most exciting agents are represented, including PARP inhibitors, including lutetium PSMA. There are some other targeted agents, such as the PI3 kinase inhibitor, capivasertib, that's being looked at in PTEN deficient setting, and abemaciclib, which is a CDK4/6 inhibitor, which in breast cancer really partners very well. It's very synergistic with hormone therapy. And there's a lot of data showing synergy in the setting of prostate cancer as well. So this is in a genomically unselected population, looking at whether the synergy of abemaciclib with abiraterone will improve long-term cancer control and survival. And then there's immunotherapy in the purple group. At least one of the studies, Keynote 991, has not shown an advantage, although we haven't seen the full data. It's just sort of a closure of the study. It doesn't mean none of the studies will be positive, especially when you throw in a drug like cabozantinib, as they're doing in the Caballos study. But, this is to say that although we have triplets, although we have doublets, there is still room to improve. We still want more patients to achieve a deep and durable remission. In the future, of course, we may have multiple different triplets, and it is hoped that we will have some kind of biomarkers to guide us so that we can start to treat prostate cancer patients a little bit more with personalized medicine. For this patient, a doublet might be perfectly adequate. For this patient, a triplet with a PARP inhibitor or with lutetium, or for this one, chemotherapy. And so there's a lot of effort going into developing those types of useful prognostic and predictive tools. So, continue to keep your eye on the literature for more data coming out from these big phase 3 trials. But overall, intensification in earlier stage disease, as we saw with biochemical recurrence and in metastatic hormone sensitive, just is a unifying theme of what's been happening in prostate cancer.